Hello, everyone. I'm Sherry with the CGH Health Foundation, and welcome to our Growing Healthier program for this month. This is a series of educational programs where we tried to give you important medical information and also gives us a chance to introduce you to some of our very knowledgeable providers at CGH. Dr. Bill Bird is the host of our program, and today he's going to be talking with CGH oncologists Dr. Ali Khan and Dr. Al Sayed. They will be talking about cancer care and some innovative new therapies that are better at diagnosing cancers and providing more personalized therapies for our patients. Before I turn it over to Dr. Bird, I just want to give you an update on some of the Health Foundation activities. We're just finished our spring auction, and it went very well. We were able to raise some money for children's programs like the Prescott Dental Health Clinic, our Eyeglasses for Kids program, our pediatric mental health programs, and our nutrition and physical activity programming in the schools. So thank you, everyone who either donated an item to the auction or who placed a bid and purchased an item. We really are appreciative of you. We want to remind everyone that the Health Foundation does administer several scholarships for students who are seeking careers in nursing or in the healthcare industry. And if you've already been accepted into your nursing program or into a healthcare field of study, you're eligible to apply for these scholarships. I think we have about 20 scholarships. The application deadline is June 12th, and you can find the form to apply on the CGH website. That's cghmc.com/scholarships. And lastly, I'd like to tell you about the Memory Cafe. You may have noticed over the last few years, CGH and the CGH Health Foundation have expanded our offerings for patients who have Alzheimer's and dementia and for their caregivers. And we now have a monthly meeting space for them to kind of all hang out together. So this is for any adult who's living with memory issues and their caregiver or a family member. It's a little less structured than some of our other activities. So it's just more of a welcoming and social gathering. The Memory Cafe is held the third Tuesday of every month at 10 o'clock until about 11:30, and it meets in the community room at 2600 North Locust in Sterling. The next one is coming up on Tuesday, June 16th. And if you have any questions about that, you can call Beth Stirk, our dementia navigator. Before I turn it back to Dr. Bird, I want to talk about next month's program. Dr. Bird's guest next month is Dr. Rafael Atassi. I have heard that cardiologists are referred to as plumbers and electricians. Some of them specialize in the vessels and some of them specialize in the electrical impulses of our heart. Dr. Atassi is one of those electricians. He's an electrophysiologist, and Dr. Bird's going to be talking about treatments with him to help discover and treat those electrical issues. And that program is scheduled for Thursday, June 11th here on Facebook Live at noon. That is what is happening at the CGH Health Foundation. And now it's time for Dr. Bird to take over and talk to Dr. Al Sayed and Dr. Ali Khan.
Well, thank you, Sherry. Appreciate the intro. Hi, yes, I am Bill Bird, Chief Medical Officer here at CGH Medical Center in Sterling, Illinois. Thank you for taking the time to watch this broadcast. I think I would call it, rather than Facebook Live, we're kind of sort of live. We're doing the interview live, but we're gonna share this recording at a later date just because of the timing of Dr. Al Sayed, Dr. Ali Khan, and myself and others. But nonetheless, here we are. We're going to do this interview, and I think you'll find it very informative. So without further ado, let's get Dr. Ali Khan and Dr. Al Sayed on. Gentlemen, hello.
Hello.
Hi, Bill. Thank you for having us.
Thank you for joining me. So, fellas, my goal here in our conversation today is for folks, first of all, to get a sense of the work that you do there in our oncology department, and also to learn more about some of the newer advances in treatments of various cancers that the two of you deal with all the time. I have a feeling you're up to answering those two things. So without further ado, I'm going to start with just, can you, the two of you kind of talk about at your offices, because I know you have offices in Dixon as well as Sterling.
Mhm.
What kind of folks help to support the work that you all do to take care of patients?
I can start.
Sure.
So, as a lot of people do, here at CGH, we have a good-sized cancer center. We have two clinics, one in Sterling in the main clinic, and we have another clinic in Dixon um, on Galena. We provide cancer care, mainly systemic therapy, including chemotherapy, immunotherapy, antibodies, stuff like that here locally to our patients. We have two medical oncologists, myself and Dr. Ali Khan. We have a nurse practitioner, Lindsay Rodriguez. We have a big supporting team. We do have two nurse navigators. We have at least 10 certified chemo nurses and a lot of other supporting staff as well.
Anything you wanted to add to that, Dr. Ali Khan? Thanks, Dr. Al Sayed.
Yeah, recently, we have oncology pharmacist on site, and we have social worker, and we have a department called prior authorization department, where the person looks into the chemotherapy or immunotherapy ordered, make sure it's all covered with insurance and all. And not the least, we have volunteers, they help patients, to go to their restrooms and serve them coffee, snacks, and lunch like that. So it's
Yeah.
a pretty big department with a lot of people helping us out.
Yeah. Before I go into the cancer questions, Dr. Ali Khan, could you talk a little bit about our COPE designation and what that means? Because I know you were the person who really pushed us to make sure that we had that designation.
Sure. Just to give the background, we have our national society called American Society of Clinical Oncology, ASCO for abbreviation. And in 2010, they started a voluntary program. They invited the practices all over the nation to participate in this program. Basically, what it does is to make sure that we are following all the standard of care. So they started in 2010, and with the blessings from Dr. Bird and the administration, I thought we should participate in that. So I'm very proud to say we are the first practice in the state of Illinois to be certified. So the certification process, involves kind of auditing our, care by sending some people, every 3 years. So make sure we are following standard of care in how we prepare chemotherapy, how it is administered, and are we following all the standard guidelines in supportive care, not only in chemotherapy, but supportive care like anti-nausea medications and all. So I'm very happy that I've got a very strong team and we could accomplish this goal. And it keeps on going since 2010. We are now 16 years out. Every 3 years they come, and every year we have to submit some, they call modules. For example, the common cancers, lung, breast, colon. So make sure we are staging them properly and offering them properly.
Yeah. Yeah. Good. Okay. Thank you. Thank you for the explanation about everything there. And I've been up on and you up where you all practice, and yes, you have a great team that does a lot of work to kind of help you guys set the direction, and then they really help you to make sure the ship is sailing in the right direction for patients. So, okay, let's get into it though. In terms of some different cancers that the two of you take care of patients for. So, I'm going to start with you, Dr. Ali Khan, and can you just, for the folks who are listening, talk about how the treatment of something called multiple myeloma has changed in the past several years?
Sure. It's a very exciting area for all the malignancies now. Multiple myeloma, just would like to give the background. It was recognized as a disease entity way back in 1845.
Wow. Okay.
Yeah, a gentleman in London actually was a grocery shopper. I'm very fascinated by the history of medicine. So if you allow me, I'll just share in 1 minute, this story about multiple myeloma. So this gentleman, 30-year-old man, has been having back pain, severe pain, and mostly chest pain, and they didn't have anything to offer. They were offering whatever remedies they had, including cupping and pain medicines. So the physicians at that time, they used to pay attention to the urine specimens and simple blood count. They had only simple microscope.
Yeah.
The physician noticed that the urine had some clouding when he boiled it. So he thought that is a protein. But when he kept the tube aside, it melted away, it dissolved. He never saw this phenomenon before at all. So he called his colleague, his name is Henry Benz Jones. He said, what's going on there? So, so since that time, we call this protein as Benz Jones proteinuria. And
Okay.
back, 100 years later, we know those are the light chains. So basically, it's a disease of the bone marrow where there are a lot of plasma cells, and they are small little factories producing these immunoglobulins. They get accumulated in the blood, and they can shut down the kidney, so the patient's present with kidney function abnormalities. And those proteins and some of the other chemicals, we call them cytokines, eat away the bones. So they produce what they call as classical punched out lesions, especially in the skull bones. So that was the classical finding they had.
Mm.
So patients can come with pain in the back because of bone lesions, or they can come with fatigue, tiredness because of anemia, or when they come to ER with dehydration,
Mm.
and the ER physician sends the lab, they find the calcium is very high. That's how these people get diagnosed, and we get a call, and we do the bone marrow and other testing to find a myeloma. So traditionally, the treatment has been with chemotherapy. We had only two medications called melphalan and prednisone. And later, then we got some chemotherapy drugs called vincristine, adriamycin, cyclophosphamide. So when I was in medical school, even during my residency, the average survival was 2 years.
Hmm.
So things changed suddenly in the late 90s when a drug called thalidomide, came into use. Bill, if you remember, this medicine was synthesized in Germany as a sedative medicine.
Oh, okay.
It was given as a pill. In fact, it was sold over the counter those days.
Huh.
So people, we use always off-label use. So they
Yeah.
started using in pregnant women with morning sickness. So what happened? The kids born to these women who had this pill, they were born without the limbs.
Oh,
So
okay.
Phocomelia. So that pill was banned, and thankfully it never made its way to US.
Mm.
So because of the FDA regulations and all it never made it to the US. But somebody behind the scenes was researching on the drug. Why did the fetuses lose the limbs? So there is something they call decreasing the blood supply. We call that angiogenesis. So somebody stumbled on the multiple myeloma and a long history. Then the drug was tested and it produced marvelous results.
Mm.
So that was the first compound, thalidomide. And then we got second generation of those group of drugs. We call them IMiDs, immunomodulating agents. We had a drug called lenalidomide and a newer version called pomalidomide. So the combination of these drugs made a big difference. People went into remission and lived longer. And a lot of research, I will just fast forward in 2026, we treat myeloma with a combination of 4 medicines. We call them quadruplet regimen. There is an antibody called daratumumab against the plasma cells, and combined with a drug called Velcade, which is a proteasome inhibitor, combined with this drug called lenalidomide and steroids. So majority of the people go into remission, and to maintain the remission, we send them for stem cell transplant if they're eligible. There is an age criteria, health criteria, not only the age, the biological age which matters, not the chronological age.
Mm.
Some people may be 80, but still eligible for a transplant.
Yeah.
Then they go on maintenance treatment with a pill, usually lenalidomide, or we stratify patients into low risk and high risk. So from a lethal disease for 2 years survival, it has become like a chronic disease, like diabetes and hypertension. But these people have to be on maintenance treatment. And there are a lot of new antibodies coming. We call them bispecific antibodies. The stem cell transplant, I spoke about that. Now we've got something called CAR T cell therapy, where we take the immune cells of the patient, train them, engineer them, and infuse them back into the patient. So,
Yeah.
so we have patients in our community more than 10 years out with myeloma.
Mm. Yeah. Yeah, that's so good. So good to hear. Yeah, you don't want to have cancer, but in terms of myeloma, it is, as you said, for some people has become more of a chronic disease that needs maintenance. So really exciting. Okay, well, thank you. Appreciate that, Dr. Ali Khan. All right, Dr. Al, I wanted to ask you about the latest advances in something that is very common as well, and that is breast cancer. Can you speak to the folks who are listening about some advances in breast cancer?
Okay, so as you said, breast cancer is the most common cancer in women. And, I don't have the actual numbers, but I do believe that it is the most common thing that I see in my clinic, and I think in Dr. Ali Khan's clinic. Um, and the treatment has changed, dramatically over the last 10, 15 years. And that is because we're moving more toward personalization. So we don't use chemotherapy on every patient anymore, and not every breast cancer is the same. We kind of choose the treatment, or we tailor the treatment, based um, on the biology of the tumor. So I'm going to give a few examples to try to break it down. Um, so the first example is, patients who have hormone receptor positive, which means that the cancer cells carry these receptors where the hormones, the female hormones, kind of fuel the cancer cells. So if we find that, we start by using more targeted treatment. The newer treatments called CDK4/6 inhibitors, these are pills. And in combination with the traditional hormone therapy, they have shown an incredible outcome, better prognosis, better survival, significantly less side effects. The other good example is people who have other type of receptors called HER2 receptors, and we have multiple options for HER2-directed therapy, and there's a lot of new of them, coming soon. Um, Dr. Ali Khan mentioned immunotherapy. This is something we recently started using in breast cancer. It is used in very select cases, such as very aggressive, cancers called triple negative. That's when we don't have any receptors. So we combine it with chemotherapy and has shown, very good results. The new thing in breast cancer is something called antibody drug conjugates, which are molecules designed to deliver chemotherapy to the cancer cells, and that will, reduce the, damage to the healthy cells, and of course less side effects. I just have one more point to talk about. There's another very important shift in our practice, where we are sometimes able to avoid chemotherapy in early cancers, if we find them, and that's by doing some kind of genomic testing that will give us a better understanding of the the aggressiveness of the cancer, or the risk of the recurrence, and then we will choose which patients
Yeah.
and which are not.
I catch you guys do tumor boards every couple of weeks, and I've also heard you talk about some breast cancer patients who you do some of your treatments first before they have surgery, and also some where they don't necessarily do radiation therapy where they would have in the past. Can you talk briefly about those two situations too?
Right. So it depends on as it's, same thing, same concept. It depends on the type of the cancer or the receptor status. In general, people who have HER2 positive disease or triple negative disease, their cancer tend to behave more aggressively. So for these patients, if we find that the tumor is bigger than a certain size, or if it had moved to the lymph nodes below the armpit, then the recommendation is to use, chemotherapy, or what we call neoadjuvant therapy, so treatment before surgery. So the goal is to try and shrink these tumors, so the patient will not have a major or big surgery, as if we start with surgery. And then also, there is a very important point. We're kind of, testing the water. We're seeing how this cancer is going to behave. Like a very good sign, if we do this treatment and the cancer tumor vanishes, we go to surgery and we don't find any residual disease. That's a very good sign. And that will also tailor what we do after surgery, which what we call adjuvant therapy.
Yeah. Yeah. Good. Thank you very much. Let's get Dr. Ali Khan back on, and I want to move on with Dr. Ali Khan to talk about colon cancer. So can you kind of talk about some new advances in colon cancer, Dr. Ali Khan?
Sure, Bill. Thank you for that question. Again, this is a very common cancer as breast cancer is. We get a lot of colon cancer patients, and the general principle, applies as in every cancer. We have to first stage the disease, stage 1, 2, 3, 4. If it is only stage 1 localized to one area and not gone to the lymph nodes, little bit confined to the wall of the colon, then surgery is only treatment. Then we have a stage 2 disease where still it has not gone to the lymph nodes, but it has penetrated the wall of the colon a little bit more than the stage 1. So this is the most challenging for oncologists to talk about, because not all stage 2 patients need chemotherapy. So surgery may be curative in them. So who needs chemotherapy? They're having, criteria like somebody who came with obstruction of the colon, or if the tumor has perforated, or if the tumor appears to be what they call as poorly differentiated under the microscope by the pathologist, or there is something invading the small vessels, we call that lymphovascular invasion. So those were the classical risk features we had, and we have to sort these cases out. Who needs chemotherapy, who doesn't. Then there is something called microsatellite instability, which we are testing in every colon cancer patient. So there are two things with this test. Number one, it is done on the tumor specimen. So some of this testing could indicate that the patient may have what is called as hereditary colon cancer running in families. It's called hereditary non-polyposis syndrome or Lynch syndrome.
Okay.
So the second value of this test is sometimes it could not be hereditary, just sporadic, meaning just in the tumor itself, not in the germline mutation in the patient. So these patients do not respond to chemotherapy, the 5-FU-based chemotherapy. So stage 2, it's a standard thing we see, we call them microsatellite unstable, or they are stable. So if they are unstable, their prognosis is good, they don't need chemotherapy. So I'm talking about the stage 2 patients whose cancer has not gone to the lymph nodes. So we have that information for a long, long, long time. The latest thing is we are doing what is called the circulating tumor DNA in the blood.
Okay.
So basically, it looks like the DNA coming out from the colon cancer cells in the blood, and we measure around 6 to 7 weeks after surgery. To avoid false positives. If that ctDNA, we call ctDNA, circulating tumor DNA, is negative at 6 to 7 weeks, these patients do really, really good. They may not need chemotherapy. So that is a major breakthrough. Instead of relying on the traditional factors we had. So we do the ctDNA and we can monitor them every 3 months. So in our clinic, recently I had a patient like that, elderly patient who I saw in the hospital. She was just recovering from surgery. And at the outset, she told me, and by the way, this was her second colon cancer. The first one was 16 years ago.
Okay.
That was stage 1, and she had resection of half of the colon, cured, no chemotherapy. She saw me only once or twice, and I told her, you don't need to see me, just follow with the GI. Have colonoscopy every 5 years, you're done.
Yeah.
Unfortunately, she got the second cancer, which is a new cancer. It has been removed, stage 2, and our surgeon, Dr. Kim, removed 35 nodes, all of them were negative. So everything is in her favor, but the tumor was a little bit more extensive. So I'm waiting for the ctDNA on her.
Okay.
So we just got the blood test drawn. So
Okay.
and then we'll make a decision based on that. So she had averse to chemotherapy, but I told her, let's do this test.
Yeah.
So that is a stage 2. Stage 3, routinely they do need chemotherapy because there is a high risk of recurrence. And stage 4, of course, is basically chemotherapy with the backbone, and surgery is done if the cancer is obstructing the colon or there is a bleeding. So important breakthrough has been the role of immunotherapy. Again, the microsatellite unstable tumor stage 4, they don't need chemotherapy. So this is something exciting in colon cancer. About 5 to 6% of the patients belong to that category. They're spared of chemotherapy, they just need immunotherapy. So that is a major breakthrough in the last year or so in the colon cancer. So
Yeah.
they did this long study, a trial comparing chemotherapy versus immunotherapy alone. So immunotherapy was as good as the chemotherapy.
Wow.
And
Okay.
we do have a couple of 2 or 3 patients who were eligible for immunotherapy.
Yeah.
And talking about the colon cancer, just want to talk about the rectal cancer, the lowest part of the colon, the rectum. So traditionally, the treatment has been we do chemotherapy, radiation therapy, and they do go for surgery. So in this arena also, the same thing applies. If they are eligible for immunotherapy, they get immunotherapy, not chemo. And we are trying to curtail down the treatments. There is something we call total neoadjuvant therapy, meaning just give chemotherapy and chemo plus radiation and monitor the patient without surgery.
Okay.
So these are all new ideas and being implemented, being brought to the clinic, that have been tested. So, but those patients require very, very close follow-up from the colorectal surgeon and by imaging, by doing MRI, things like that.
Yeah.
So few patients can be spared of surgery, just treating with chemotherapy and radiation therapy.
Yeah. Very interesting. So now we're using the blood and DNA in the blood about whether or not
Yeah.
treatment is needed and immunotherapy and colon cancer. So very interesting. All right. Well, thank you, Dr. Al-Sayed. Let's talk about melanoma, skin cancer. Tell the folks who are watching what's new in the treatment of skin cancer.
I'm actually very excited to talk about melanoma. It's probably one of the best examples, of how far cancer treatment has come in the past 10 years. So, 10 or a little bit over 10 years ago, advanced melanomas were one of the most difficult cancers to treat because of the lack of good options, and even we had very few options for treatment, and they did not work very well, and they were super toxic. And then in 2014, the first approval for immunotherapy was actually in melanoma.
Mm.
And then we started using immunotherapy in the rest of other cancers. So immunotherapy, think about it this way. It's not chemo. It's not as toxic as chemotherapy. It's where we use the patient's own immune system to help recognize and attack and kill the cancer cells. So we're utilizing the patient's immune system, to fight the cancer.
Mhm.
So then immunotherapy got approved in melanoma, and that has shown a very long-lasting, response, and improved the survival significantly. And then the other line of treatment that came and got approved also a few years ago, which is a targeted therapy. About 50% of melanoma patients will carry a mutation called BRAF or BRAF, and that's on the cancer cells, not on the patient's DNA.
Okay.
And if they carry the BRAF mutation, we have BRAF inhibitors, which they actually work very rapidly on shrinking the tumor. But for durable response, we like to either alternate or mix them with immunotherapies.
Okay.
And there's another important change, that we are using these treatments now in the earlier stage is neoadjuvant or adjuvant therapy. The same concept we talked about with breast cancer. So either
Okay.
make surgery smaller, or after surgery we do treatment for stage 3 to prevent the cancer or lower the risk of the cancer coming back.
Okay. Is melanoma trending towards what Mira was talking about, Dr. Ali Khan was talking about with multiple myeloma, as maybe not, if not completely, somewhat of a chronic disease with these new treatments?
I would be hesitant to call it, chronic disease. I have few patients who are survivors for more than 3 or 4 or 5 years now, which was unheard of 10 years ago.
Mm.
And now there's a new term emerging in the melanoma, which is cure, because some people respond very well to immune therapy, where we stop treatment after 2 years because there's no evidence of any disease anymore.
Hmm.
So, I mean, I think that's the highlight of the advances of melanoma.
Yeah.
I think still there is a lot of work to do, and there's new treatments, getting approved now. There's something called TIL therapy, or tumor infiltrating lymphocytes, which is very similar to CAR T cell or these immune.
Okay.
They
Okay.
train the immune cells to fight the cancer cells.
Yeah.
So there's a lot of new things coming, and I think at some point we're gonna get to call it a chronic disease. Not
Yeah.
quite yet.
Yeah. Okay. Very good. All right. Well, thank you. All right, Dr. Ali Khan. Last cancer I wanted to talk about was lung cancer with you guys today. Can you talk a little bit about advances in lung cancer treatments?
Sure, Bill. You're covering almost all major cancers, we see in our practice.
Yeah.
Lung cancer nationwide is, one of the common cancers. More than 200,000 people are diagnosed every year, and high mortality rate. Most of them are smoking related. And, just to put in perspective, we used to classify lung cancer as non-small cell and small cell. Small cell lung cancer always had chemotherapy because it's most aggressive. And non-small cell, the treatment was, the patient can tolerate surgery, and the tumor is small, they go with surgery, resection. And if it's not resectable, then they get chemotherapy, radiation therapy, or if it is advanced, then it was chemotherapy. That was the paradigm we had.
Okay.
But now, as in all other cancers, things have changed a lot. Now we are going for something called targeted therapy. So every lung cancer patient, especially the advanced lung cancer patient, we do something called a next generation sequencing to look for targets in the tumor. So there are certain patients who may have something alteration in the lung cancer gene, something called, for example, EGFR mutation. That was the first one to be discovered, and they can be treated by a pill. I'm talking about advanced lung cancer patients with EGFR mutation.
Okay.
So, and then the results have been very, very successful just by a pill. A pill a day, and you take it nonstop. It's because stage 4 is non-curative. So these concepts have come to the early lung cancer. Even stage 2 and 3, if they have a little bit locally advanced lung cancer. So there is a data to show that after surgery, these pills in combination with chemotherapy have good control of the disease for many, many years.
What are the pills again? What are the pills? What's their mechanism of action?
Well, they block. They are called the small molecular inhibitors. For example, EGFR receptor, it is a receptor on the surface of the cell.
Okay.
So it belongs to the same family of HER receptor which Dr. Alsay was talking about the breast cancer. So
Okay.
there's a family of what we call as epidermal growth receptors. So on the surface of the cell, imagine there is a receptor and something binds to it, give it triggers so the nucleus will divide more. So they discovered chemicals which can block that receptor. So in blocking that, the nucleus of the cell, cancer cell, does not get a signal to divide more, and that's how the cells die. So
Okay.
similarly, there is something called ALK, something called ROS, MET. For each of those mechanisms, they have unique chemical compounds in the form of pill.
Yeah.
So that's one very good kind of precision medicine we had. And of course, as in all other cancers, immunotherapy had made a very, very big, major breakthrough in lung cancer management as well. There is something we call PDL1. It stands for programmed death ligand expression. We see on the surface of the tumor cell by doing stains on that. If a stage 4 lung cancer patient has PDL1 more than 50%, they don't get chemotherapy. They just get immunotherapy.
Mm.
So less toxicity and better response rates. So in general, Bill, immunotherapy has made a major breakthrough in almost all malignancies. And then there have been improvement. We are not talking about radiation therapy, but there have been improvement in radiation therapy as well. Guided stereotactic radiation therapy. We have facility in our Dixon facility as well, Northern Lung Cancer Treatment Center, where the radiation therapy can be targeted. Unfortunately, some patients are bad COPD, they have bad lung function, not tolerate traditional radiation therapy, so they can be focused only to the tumor.
Yeah.
So,
Yeah.
one more, Bill, thing we are doing is same thing, the ctDNA, we are monitoring lung cancer as well.
Okay.
So after the treatment, you measure the DNA, ctDNA, and
All
then
right.
you go sequentially to find the recurrences.
Yeah. I wanted to ask a couple more questions. We're kind of getting close on time here, but you just talked about blood testing again and everything. I know there's a lot of information out there about genetic testing just in general for your risk of of getting some type of cancer, or can you two kind of talk about your perspective on that type of testing?
Yeah, genetic testing, it's good to find cancers. in people early on, or we can do some preventive steps, but it has to be very targeted and focused. If you do general, there are so many commercial companies which send a kit to the patient, you put your saliva specimen and you get it. We don't know what to do with that information.
Mm,
Whenever we do a test, we should have a plan, actionable plan.
mm,
So the known familial cancers, for example, we started with the breast cancer. It used to be BRCA1 and 2 testing, not in everybody. In
yeah.
patients who are young, who have got family history, or who are from, say, some different kind of Ashkenazi Jews, and they have the higher risk. So those were targeted. Then
Yeah.
we expanded to other cancers. For example, colon cancer, I touched base on that. There are families who have colon cancer at a younger age, below 50. And if there are 3 generations of colon cancer in a grandparent, those are the high risk group. If we apply genetic testing for the general population, then we are, opening a can of worms.
Mm,
We don't know. It will create anxiety, right? Sometimes the report says a gene found of unknown clinical significance, or
mm,
a variant of unknown significance. That's the word you use. So what do you do with that information? Nobody knows. So, I'm a clinical oncologist, so is Dr. Al-Sayed. We treat patients. So we are not authoritative on the genetic thing. The best thing is to talk to a genetic counselor before the test, get the test done, and have genetic counseling. What needs to be done for screening? Who needs to be screened with the family, siblings,
okay.
children like that.
Okay.
I would not recommend a blanket genetic testing. One size fits all. It's not the thing. I don't know. To also you can have.
What would you say, Dr. Al? What would you say about that?
I do second what you just said. That was the point that I was trying to make, that I think genetic testing is very useful in certain cases. Of course, people who have like strong family history, or people who are diagnosed with cancer at very young age. But I think it has to be done through a genetic counselor, somebody who studied genetics and trained and knows what to do with these results. I mean, there are, basic things that everybody knows, every physician know, but if you dig deep into it, that needs to be done by a genetic counselor.
Okay.
I want to give you one example, Bill. I just saw a patient whose 3 family members have renal carcinoma.
Okay.
The patient, brother, and his nephew.
They have renal?
Yeah, renal.
So they have kidney
Renal
cancer, just for
great cancer.
Yeah.
And we did the genetic testing with a more than 81 gene panel. Everything is negative.
Okay.
So this is the patient who needs to see genetic counselor. There could be some genes which we are not identifying in that panel, right?
Mm.
So it creates a little bit complexity even in known cancer patients.
Yeah. Very good. One last question for the two of you, and I'll let Dr. Al take the first crack at this. But obviously, cancers are becoming more and more complex. The two of you deal with a lot of different types of cancer at our center here at CGH. Can you talk about how you incorporate information and expertise from bigger centers into the work that you're doing here at CGH?
So we actually work very closely with a lot of big cancer centers and academic centers. As you said, cancer is becoming very complex. I mean, me and Dr. Ali Khan, we're in community practice, so we see everything. So every now and then you see a very rare type of cancer or a very unusual presentation, So we use the expertise of people who work in big centers who are experts in the field. So we built very good relationship with these people over the years, and we send patients to them, for recommendation. We also send people to big cancer centers for specialized procedures. There's big surgeries that we cannot offer here in our area. Bone marrow transplant, CAR T cell therapy, the treatments that we were talking about. And because, we've been working with them for years, we got really close to some of the experts in the field. And, we call them and say, hey, I have a patient. Can you see this patient for me? And they do a very good job. The other thing is also big places offer clinical trials, which we do not have here. Those are experimental drugs.
Mm-hmm.
And some patients are interested in that. So we, send them in the right direction.
Yeah.
I just want to make one comment. I think the big thing that happened recently at CGH is implementing or going live on Epic. That's our medical record.
Mm.
And because a lot of these big cancer centers and a lot of big universities around the US use Epic. So it is much easier to communicate with these places now. We easily can share medical records with them. When our patient goes there for a special procedure or something, I can follow on the patient, see what's going on,
Yeah.
and know exactly when the patient's going to come back to us to continue their treatment. So I think Epic was a very good thing that happened, and we're so glad we went with it.
Yeah, very good point. Thank you so much. Dr. Ali Khan, anything else you would add to what Dr.
No, I do really second that. We have very close contact with all the major academic centers in Chicago and UW-Madison, Mayo Clinic. Some of them have visited our facility as well. So we have their, contact numbers. We can just text message them. And just one word I would like to say is the traditional chemotherapy, immunotherapy is the same, whether the patient gets here or in any tertiary center. We send patients for one or two reasons. Number one, for second opinion, so the patient and their family are happy we're doing standard of care. And secondly, what we cannot offer here. For example, bispecific antibodies, first dose is a little bit cumbersome. So we do have now patients getting the first dose somewhere else, and we take over here. And once we have hospitalists and everybody is comfortable, we can start doing that. That's another area. Just wanted to give one example of multiple myeloma. You talked to me, Bill, when we started the talk.
Yeah.
There's a patient I'm following since 2005 who had something called MGUS, and it turned into myeloma in 2006. So she wanted a second opinion at Mayo Clinic. I sent her there. She came back with what I recommended. She got chemotherapy. She got stem cell transplant at Mayo Clinic. And then she had a relapse, poor lady. So she's still, on treatment since 2026. The reason about it is not every institute has all the expertise for every malignancy. So Mayo Clinic wanted to put her in a trial, which they did not have. It was in UW-Madison.
Okay.
So they arranged for her to be seen at UW-Madison, and she got enrolled in the trial over there. So this kind of collegiality we do have.
Yeah.
In a small community center, any hospital, it's patient choice, but we have connections. I had a patient who wanted to go to MD Anderson for a second opinion. So we made that happen.
Yeah. Yeah. Very good. Well, I in respect of your days, and I know you have things you need to get to. So I thank you for spending the time and talking about a lot of things related to cancer with me. For the folks who are watching this, what I would hope that you would take from this is obviously some very good information about different types of cancer that you or your loved ones or friends might be experiencing, and just knowing more about them, but also just the sense that at CGH, under the leadership of Dr. Ali Khan, Dr. Al-Sayed, if you have a cancer, and who wants one, but if you end up getting a diagnosis of a cancer, these two gentlemen and their team can do a fabulous job of taking care of what's going on with you and what cancer-related needs you might have. So we're so fortunate to have Dr. Ali Khan and Dr. Al-Sayed and the rest of their team here at CGH. So, gentlemen, thank you so much for your time. Thank you for the work that you do, and glad to have you on the broadcast today.
Thank you, Bill.
Thank you for having us.
Yeah. Okay, I do have one slide. Just as a reminder, Dr. Atassi will be joining me in June, and we will be talking about all things electrical in patients' hearts. So looking forward to that, because there's some interesting and exciting things happening in that field as well that Dr. Atassi will be able to share with us. So until then, thank you for taking the time to watch this. And I will be doing this again in a month. And until then, thank you for watching.